Hi everyone, welcome to our Bertolotti Syndrome meeting where there's focus today physical therapy. My name is Kit. I am the Bertolotti Syndrome founder of this platform, and I've been hosting these monthly meetings. And today we have a very special speaker. We have with us Dr. Melanie Carminati, and a bit of a background about Dr. Carminati. She obtained her Doctor of Physical Therapy degree at Drexel University and has over 14 years of experiences. And she's the owner and co-founder of, owner and founder of Inspira Physical Therapy, which is located in New York City. And she established this back in 2018. She's highly specialized in ortho and pelvic physical therapy, and she has treated many Bertolotti patients as well as other often associated conditions such as EDS and CCI. She's also the co-founder of the New York Hypermobility Collective, where she's leading monthly webinars and featuring specialized providers who are involved in the care of EDS and HST. So thank you so much, Dr. Kamidani, for joining us. We appreciate your presence, and we are very excited to hear more about your PT experiences on Bertolotti patients. So without further ado, I would like to give the floor to you. Welcome.
Kit, thank you so much for having me. Hello to everyone who's tuning in. I was excited that Kit reached out to me because there are many populations of patients who, in terms of physical therapy, they are often seeking, very specific care, and it takes a provider and a physical therapist who is curious and is experienced who can provide the proper care. So my hope for today is to give some general information about what I do with patients who have Bartolotti syndrome and what has helped them. And then also I'll be here for some Q&A as well. So if you all just give me one moment, I'm going to try to share my presentation. There's always a little delay for that. So let's just see if that worked. Can we see the presentation?
Yes.
Okay. All right, so as Kit said, my name is Dr. Melanie Carminati. I will be presenting today about physical therapy for Bertolotti syndrome. Disclosures, I am a licensed physical therapist in New York State and the owner of Inspira Physical Therapy Practice. We are a cash-based and out-of-network practice, and I have worked as a trainer for Winback. They are a radio frequency company, and I've used their Takar device for training. So hello again, my name is Melanie. I'm the owner of Inspira PT and Pilates. I am a doctor of physical therapy with 12 plus years of clinical experience treating chronic pain, pelvic floor dysfunctions such as pelvic pain, endometriosis, and other complex orthopedic conditions, including EDS and HSD, with concomitant conditions such as Bertolotti's, POTS, CCI, etc. I'm an educator. I'm also a nationally certified Pilates teacher, a medical conference and event organizer, and as Kit mentioned, co-founder of the New York Hypermobility Collective. This is a informational webinar, so everything that I'm saying is not individualized medical advice. So please follow up with your medical provider, healthcare practitioner for any specific guidance to your unique needs. So the agenda will start with just talking about Bertolotti syndrome, although I am certain that everyone in this meeting is already aware and informed. I'll then spend most of the time speaking about physical therapy interventions. I'll end speaking on collaborative care, and then we'll have time for Q&A. So all of you know, I believe, that Bertolotti syndrome is the association of lumbosacral transitional vertebra. There's no definitive conclusion. There's lots of theories as to why this is happening. There's a lot of strong genetic possibilities similar to EDS and HSD, but the incidence itself, it is relatively common in patients with low back pain, 4.6% to 7% of patients. The cause, as I mentioned, remains uncertain, but there's several hypotheses. For my patients, when they are coming in and presenting with back pain, if they're having sciatica, or specifically L5 radiculopathy. That just means that the pain is radiating from a specific spinal segment from the fifth vertebral lumbar segment. If they have inability to lay flat on their back, supine position, and they have SI joint pain, in my mind, when I'm working with the patient for the first time, I'm thinking, okay, is this back pain from a disc herniation? Is this back pain from some other incident, some trauma? And one of the more specific giveaways for me when patients have back pain, if I'm thinking it might be Bertolotti syndrome and I want to send them to another provider for workup and imaging, is that inability to lay flat on their back in supine. So I'm sure many of you know that if you've been to physical therapy in the past and they've tried to have you do exercises on your back, it's common for that to not be tolerable. So there are ways, which I will discuss in future slides, to modify exercises, utilize props to progress properly and safely in physical therapy. But these are some of the common symptoms that we've seen. How does this spinal variation impact biomechanics? So as you can imagine, if there's lumbaralization or sacralization, if the segment is fused or partially fused or completely fused, depending on the type of Bertolotti syndrome, this will impact posture. This will impact how you sit, how you stand, how you sleep, the positions. From all of that, compensatory movement patterns develop. So if you are unable to have proper stability and or mobility in a certain segment of your lumbar spine, that's going to change how you use your muscles. That's also going to change how your brain sends information to the muscles that we want to be working and strengthening. So with that compensatory movement pattern, then this leads to excessive stress, asymmetrical load bearing, which can create wear and tear, which is that inflammation, I see a typo here, and damage. So with the tissue inflammation and damage, there is some other information under there that is not related. Please excuse me for that. But with the tissue inflammation and damage, we would be working from a manual therapy standpoint to try to reduce any inflammation that we can. As a physical therapist, we have different modalities that we can use. I will discuss in a future slide. As Kit mentioned, I am the co-founder of the New York Hypermobility Collective. So some of the common co-occurring conditions are hypermobile EDS, anterolisthesis, cervical spine stenosis. For myself, I have always seen my Bertolotti's patients when they also have HEDS. So that has been my experience. They come to me, they're presenting with hypermobile EDS, and when we are treating the variety of symptoms, complaints, and physical challenges that they're having, when they present with the back pain, I'm going through questions specific about where is the back pain? Is it referring down the leg? And then that question that I mentioned, how is it when you're laying on your back? So physical therapy. General education is key. So for my patients who are coming in, if I am ever suspecting it, I am always referring out as a physical therapist. I have a team of providers that I work with who are specialized in treating patients who have Bertolotti's and also know how to look for it. I have had patients who have come to me from, pain doctors, spine doctors, and their imaging that was sent to me, the reports noted nothing in regards to any transitional vertebra. And when I encouraged them to get a second follow-up with a provider who was more experienced, they took a look at the imaging and they could clearly see that there was spinal variation there. So that's one of the things that commonly happens in conversation in my physical therapy sessions with patients is, just so you know, many times this can be missed. And I know that you've had pain for a long time, and I know you've been going to a certain provider, but I think it's always a good idea to have a second look at that imaging, maybe even a second image in and of itself, but that's part of the education. in addition to pain science. So when you have pain for a long time, it changes your brain. It changes your thoughts, your beliefs. And with chronic pain, we develop fear avoidance behavior. So you become fearful to be in certain positions, to try certain exercises. So that is part of the education. From a pain relief standpoint, what we can do in physical therapy is manual therapy. So there's a variety of techniques. I do use a lot of functional manual therapy that's based on educating a patient to reestablish neutral spine, reestablish postural awareness, as well as myofascial techniques. Myofascial techniques are very helpful for patients who have muscular spasms. If there's a muscle that's commonly chronically held in a state of spasm or hypertonicity or just stuck, myofascial techniques are helpful. Takar therapy, it's a form of radio frequency. This allows for more cellular level changes because the radio frequency is administered in the form of electrical current, and I can be very specific as to where I place it, which specific lumbar segment. Maybe if I'm trying to target a ligament like the iliolumbar ligament, this is something that I use a lot with my patients, and they do get benefit in terms of pain relief. Graston technique, kinesiotaping. Kinesiotaping used heavily for posture. So I've said posture a few times, so we've listed it again there. Progressive therapeutic exercise in the clinic. So I always make sure that we're doing exercise together with the long-term goal of building a home exercise program that can be used for long-term maintenance and management. Some strategies for self-management are discussed. We all know that if you're coming into the clinic, likely we're able to reduce your pain, but when you leave the clinic, you might have another pain flare. So developing those strategies, whether it's using self-massage tools, self-myofascial tools to release, and the exercises, very specific exercises. Sleep position modification is crucial as well. I'm big on props, big on certain pillows. Some of my patients will get the maternity kind of pillows that just wrap all the way around because they really allow more variation with enough support when you're sleeping. So exercise, lumbopelvic stability and posture first. So lumbopelvic stability and diaphragm breathing is important. So when we are working with anything in the spine, we want to identify what posture feels good, what posture and position is not painful, and obviously the positions that are irritating and aggravating. Now, there's one specific prop that I want to highlight, and that is that black wedge in the bottom left square. I'm circling here. This is a Pilates wedge. As I mentioned, I am a Pilates certified Pilates teacher as well. This has been a game changer for many of my patients with Bertolotti syndrome because it allows you to be elevated and supported and not in a true supine position that is compressing and irritating any kind of fusion or partial fusion. So this wedge is amazing because it fits on the reformer. I have no financial incentive here from this company, Balanced Body, but this wedge, it fits on the reformer, so then we can do strengthening exercises on a semi-reclined position. So if you are in a clinic where they are more Pilates informed and Pilates educated, ask them if they have the wedge. The wedge allows you to just be in a position that's pain-free and or reduce pain and to be able to strengthen safely. I've put some other images of props on the sides. I'm sure you all have seen some of these, like the TheraBand, the exercise loop, different pads and such. Really leaning into the use of props has been helpful for my patients with Bertolotti syndrome because we are working and trying to strengthen in positions that are pain-free and safe. Additionally, from a movement science standpoint, from a motor control standpoint, there are many positions that we can exercise in. we don't always have to be on our back. So being with a physical therapist who understands, how to progress exercise when modifications are needed, when props are needed, is crucial for someone who has Bertolotti syndrome. And there's so much that you can do seated, standing, in different on different pieces of equipment with some minimal props at home as well. It takes a team. So, as I mentioned in the beginning, I do refer a lot to pain management and physiatry if I am thinking that someone needs a closer look at their lumbar spine, just so that the patient can get that diagnosis because it's um, more common that it is missed with providers who are less informed, neurosurgery, neurology, and physical therapy. So I always work with providers who communicate with me. There are some physicians who are just not available because they're very busy, but for me, I'd like to be able to email or call these providers and just get on the phone and let them know how progress is going so that open communication is crucial as well. Post-surgery. So I'm just putting this here briefly, but obviously I was mentioning more conservative management, but say you are post-surgery, the exact duration of each phase of your rehab will vary depending on the surgeon. And it's typically going to consist of an initial protective phase for pain reduction and neutral spine stabilization, and then eventually progressing the intensity. Very measured. And so that's another more specific phase related rehab. So I'm sure some of you are thinking, how do you find a PT who has experience with Bertolotti syndrome? I know what I know now because I was curious and because I wanted to help my patients and because they don't spend a lot of time teaching us this in school. So when I graduated as a physical therapist, I took so many continuing education courses. I read so many articles. I just stayed curious and just wanted to learn more because if you've been to physical therapy and you've had a negative experience, maybe it was a place where there were a gym full of multiple patients, and physical therapists, running around between multiple patients at once. That unfortunately doesn't allow for that individualized care, and it doesn't give you the attention you need. So I would say, if you're not in the New York City area, that's where I'm located with my team, and you're somewhere else, if you're able to find someone who has experience with patients who have EDS and HSD, that is something that could yield positive results because they will also likely see patients with Bertolotti syndrome, just like me. However, if that's hard to find a PT who is very communicative. Find someone who also was curious like me, someone who just wants to learn more, wants to hear back from you, is willing to modify, is willing to progress slowly. You're in your body, so you give us the feedback that we need so that we can progress you properly. If ever anyone is progressing you very quickly and not really listening to some of the symptoms and what's happening in your body, that's not the most conducive situation for rehab. So those are my recommendations for that. In conclusion, Bertolotti syndrome physical therapy treatments can reduce pain, increase strength, and improve quality of life. My recommendation is to find a PT who is communicative and skilled with exercise modification, as well as pain relief techniques. If you're unable to find a PT with experience, find someone open to learning. These are my references, some of the recent articles on Bertolotti's. Thank you so much. And this is my contact information I will share with Kit as well, but I'm also going to stay now for Q&A.
Thank you. Dr. Carminati. That was very helpful, I think, and I think you touched upon a lot of things that many of us are struggling with. For example, what you mentioned, like the compensation in other areas, right? It's not only one part, it's like our whole spine and our whole body is related to, the spine. So many other conditions pop up, and it's great to have a physical therapy therapist who's open to learn and also know what to do. Even though it's very tricky in a way because like our lower back pain is different from the normal usual lower back pain. So very often, I guess like I feel like many of us went through a lot of PTs. Like back then, for example, when I didn't know that I had Bertolotti syndrome. I just knew I have lower back pain, but then exercises were done in the past that were not supposed to be good for us. And I didn't know it back then, right? So, but I've been told like, oh, that's good for, someone who has lower back pain and those kind of things. So it's great to have, your experiences out there. And so that's great. And I think another thing that really resonated with me is like the fear and the avoidance, right? Like if an exercise is supposed to be good, but it's hurting me, then I try to stay away from it, or then I lock up and I just don't move in a certain way, and I just don't know what's good for me, right? So it's great to have someone who guides me through it, like basically like a personal trainer, but then for our Bertolotti bodies, right? So yeah, thank you for all the information. We have from the community, we compiled like questions, and I picked out like the 10 top questions. Um, so if I may share my screen, I can, because I put them in an Excel sheet. And then afterwards, if there are still questions from the audience, feel free to put it in a chat. And we can also go over that. Let's see. Can you all see my screen? If you see a dog, that's my screen. Um, okay, so over here, let me just, yes. So over here we have 10 questions that we voted. So for example, question number one. So the question is like, what are the most dangerous PT exercises for Bertolotti patients, even though they might be good for other lower back conditions? Could you?
Yeah, yeah, that's a great question. So I think the most common one is what is used traditionally for disc herniations, which is extension,
Yeah.
right? So if you think of the spine, um, the transverse processes and the spinous process, so the transverse process going laterally, the spinous process going posteriorly or back, if you were going into extension and you have partial fusion or just an elongated transverse process, that is going to promote more compression in the area where we don't want to cause compression. So extension is something that I would not recommend for someone who has Bertolotti syndrome. However, that being said, there are ways to do extension in the thoracic spine and the cervical spine without irritating lumbar. It takes working with a PT who can watch you, who can properly position you, but specific for the lumbar spine, we don't want to be promoting that.
Mm, okay.
It,
Um,
yes, and that is something that's very good for straightforward posterior disc herniations, which is given.
see. Okay, moving along to question two. What is your advice towards other PTs that are not aware of Bertolotti syndrome challenging spines? I know you mentioned that in your presentation. Would you like to elaborate on it?
Yeah, so for other physical therapists, again, just stay curious. I think always having a learner's mind, beginner's mind, when you're meeting with someone for the first time, because everyone's body is unique. Um, and then reading the research, so there are articles out there, and there are specialized providers like Dr. Jenkins who presents a lot. So um, try to get in as much information as possible and just develop that relationship with your patient, where you can communicate, give each other feedback. That would be my recommendation.
Um, I just thought of another, I guess the question in between is like, because like if we don't know what's per se good and the new PT also not doesn't per se know what's good, as in like good for our Bertolotti backs and not good for like usual lower back pain, uh,
Uh-huh.
how can that PT gain more information? Because on paper or like through presentation is still different than learning it in practice through someone else, like you, for example. Uh, yeah.
Yeah, I mean, I think nothing compares to having the experience. So if they are unable to read the research, maybe they can connect with the physical therapist and do some observation. Sometimes just seeing the treatment and process is helpful, like seeing it in real time is helpful.
Yeah.
Um, yes, that's what I would say for that.
Okay, thank you for that one. So question number three, someone was asking, are you able to give us a sample PT plan for a resection patient?
Yeah, so as I mentioned, it's really dependent on the surgeon because each phase of care is different. But typically, I'll speak about phase one, which is the protective phase. What we would be doing is pain management as well as education of neutral spine, making sure that everything that we're doing, if we're doing any gentle activation exercises, core activation exercises, is happening in neutral spine. Neutral spine is the safest position for spinal rehabilitation, especially post-resection, because it's not causing any excess stress on regions of the spine. Uh, Motions, like I mentioned before, extension, flexion, rotation, are not neutral spine. So being able to learn neutral spine in your body. And I'm going to also promote that if you know that you're having surgery, do preoperative physical therapy. It's so helpful to learn the exercises before surgery because your brain needs time to learn the motions and understand it. I'm not saying that every exercise you're going to be able to do preoperatively, but I'm saying most of the phase one exercises, the physical therapist should be able to position you safely to learn preoperatively, just so you at least have a basic understanding. Um, that typically sets up my patients for the best success and um, the most expedited rehab.
Yeah. Okay, thank you. Um, Moving on to question four. So there was a question asking, can you share an estimate of how long post-op you typically see resection patients? That person is starting PT 4 weeks after surgery, but doesn't know what to expect as far as like how many times per week or length. Um, just looking for a ballpark.
Yeah. So I guess it depends. So in my clinic, in my office, we see one patient an hour. We are cash-based and out of network, and so we're able to do that. So we typically see patients once a week. Sometimes if it's immediately post-op in that situation, 2 times a week. So if you are going to a facility where they spend maybe 30 minutes or less with you, you'll likely be going to PT 2 to 3 times a week for the first 8 weeks, I'd say. Um, so that is more of a more common in-network situation. But in terms of the entire duration, how long you would go, um, I would say minimum 16 weeks.
Yeah. So question number five, do you treat Bertolotti patients who had resections versus fusion differently? If so, what exercises are different?
So I would say the main differentiation here is after we're out of that phase one, that protective phase, the neutral spine phase, there is potential to safely introduce pelvic mobility more and more spine articulation in those who have had a resection versus a fusion. So with the fusion, segments are limited intentionally from moving, so we don't want to try to promote movement in that level. So that's the reasoning behind that.
Okay. Thank you.
Mhm.
So question number 6, what is your experience treating Bertolotti's patients pre-op versus post-op?
So this is more of a general question. I'm gonna say I think maybe they're asking that what they're really wanting to know is maybe what the outcomes are. So it's really dependent on the person. But depending on the transitional vertebra, depending on lumbaralization versus sacralization, if there is a full fusion, it's kind of all over the map. So I've had some patients do relatively well pre-op and do better post-op, but I also have many patients who post-operatively they're still having pains and compensatory things happening, and that's very, very normal. So, as I mentioned in one of my earlier slides, when the spine is impacted, the biomechanics are impacted, how weight is transferred in your body changes, and that can cause wear and tear in other areas. So, post-operatively, it's very possible for some other things to pop up. Maybe you could end up with more intense hip pain than you had before. Maybe you could end up with something in your thoracic spine. And this is all because the surgery has modified how your body transfers weight and how it absorbs force. So, but it's so individualized. So some people have less compensatory things show up post-operatively than others, but in full transparency, there's still some aches and pains that might show up that are a little bit different than what you had pre-operatively.
Sure. Thank you for that. So question number 7, what's your experience treating Bertolotti's patients with different subtypes?
Um,
Type 2 and type 3, type 4.
okay.
Yeah.
So, what I have found is when we are dealing with type A, no matter what, unilateral, we are able to progress exercises a little bit faster. When there's type B and both sides are involved, this is challenging for exercise progression. But yeah, honestly, I don't use the subtypes a ton because I think what matters most, besides the categorization, the classification, is the size, right? Or like the proximity of the transverse process with the sacrum, with the ilium. So I really base it more on the MRI and the imaging, the CAT scan, to see what's going on with that person, because it's really the proximity of the transverse process and whether it's fused or not that's going to impact everything more so than the categorization. And I haven't been using Jenkins classification, so maybe I will very soon.
Um, Question number 8, do you typically find that muscle groups around the pelvis area tend to learn to misfire, switch off in BSI patients? And do you recommend EMS to help correcting this?
It's a good question. So lumbar multifidi, number one, So lumbar multifidi is one of the main stabilizing muscles. I find that that's under fired. QL uh, will be over firing, and EMS to strengthen the muscle. I have not used EMS for that because I find that um, yeah, I find that majority of my time is spent if there's that muscle compensatory pattern going on in relieving the QL and then trying to just re-educate the patient in regards to posture, but I haven't used EMS for muscle strengthening in the lumbar multifidi, no. Yeah.
Question number 9. Are there specific certifications or specializations that we should look for when choosing a PT? I know you mentioned EDS, HDS, PTs.
Yeah, I would say besides EDS, HSD experience, someone who works with patients who have scoliosis will have more understanding as well. And will also have an exercise progression that will be safe.
Yeah. And then I know I mentioned we have the top 10 questions and I have 11 questions here, but these two kind of like go together. So for extra L6, Bertolotti spine patients, what exercises are safe? So do they need different exercises?
It's a good question. I don't necessarily differentiate um, in that way. I more just base it on uh, the patient and how they're doing. But sometimes some exercises that I do with patients who have the extra L6 work for them and then others don't. And again, I think that has more to do with the proximity of the transverse process and if it's fused fully or partially. So I don't have a lot to say for that. And it's just super dependent on the patient.
Mhm, mhm. Okay. Okay, well, thank you so much for answering these questions. I see my screen popping up anytime there are questions. So I see that there are other chat questions. Um, I do have maybe two less questions. One is, so do you take insurances or did you just mention before you're only out of network?
Yeah, I am out of network, cash based. Yep.
Okay, okay. And then the other question is, let's say, we have PTs that are new. Would you be open and to, for example, if there's a question to that we can connect them to you, or is that, yeah,
Yes, totally open to that.
yeah, yeah. Okay, that would be very helpful for us to know, what exercises we can do and to have a PT that can be more, I guess, like on the educational side to others. So that would be very helpful. Thank you for that. I will stop sharing my screen. I know you mentioned that you only have 40 minutes and it's exactly 12:40.
Mhm.
I see 10 questions, I think, in the chat. Do you have time to answer some of these or
Could probably do one, maybe two more.
okay, yeah, sure. Would you like to pick any of these?
Okay, let's see. Um, how do weak paraspinal muscles, I'm just going from the top, how do weak paraspinal muscles affect our condition? So, in correlation to lumbar multifidi, the weak paraspinal muscles will impact your ability to do the postural endurance exercises. So, but more important from my standpoint is the deeper stabilizing muscles. So I always try to target those deeper stabilizing muscles first. The paraspinals are more likely to overwork. So I always go for the deeper stabilizing muscles first. This is just a biomechanics understanding. The closer you are to the spinal segment, which the lumbar multifidi are, you'll be able to strengthen and stabilize and get more benefit, and then follow up with any kind of paraspinal strengthening afterwards. And then Emma says, yes, we can. I'm not sure what that was in response to, but yes, we can. Okay. And then the last question I'll answer live is from Katerina. What do you think about planks for Bertolotti's? My PT has put them on my plan, but whenever I do them, they cause my lower back muscles to tense up to the point, oh wait, hold on, which it's unbearable. So depends what kind of plank you're doing. I wouldn't have you do planks right away, because we need to talk about posture and all other positions first. But it's super common. Remember, I mentioned extension. Yeah, you don't want to be doing. It's super common for people to go into extension in their lumbar spine when they're doing a plank, and that is irritating. So, um, I'm not sure what phase you're at in your rehab, Katerina, but yeah, maybe if you have a good relationship with your PT, ask them if there's something they can do to build you up to that exercise. Ask them to watch you and to give you the corrections to make sure that you're in ideal position. Otherwise, it makes sense that if you're doing a full plank with hands down, arms extended right away in your program, that's a lot if you're not able to sit up, without having pain or other positions. So,
Yes. Thank you so much, Dr. Carminati. I see a couple of other questions. Would it also be okay if I, sum them up and then email you later so that we can still get some answers? And because I don't want to take too much of your time, I know 12:40 was like a hard cut for you. So yeah, thank you so much. I think we've all learned a lot. There are still some good questions in the chat, but I will um, connect with you later on. And yeah, I think we're all very grateful for your presence here and your experiences that you shared. Thank you so much. And well, we'll keep in touch. And yeah, thank you.
thank you all. Thank you, Kid. And I am happy to answer any questions afterwards.
Okay, thank you.
Take care.
Bye.